This EMS and Systems of Care webinar series is supported by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. They have a new service, NCDR eReports EMS, that will take support of quality improvement for EMS and systems of care for acute myocardial infarction patients to a whole new level. For more information, visit acc.org/eReports EMS. So, the management of the legendary but fictional Somewhere County EMS has started to monitor the EMS first medical contact to initial 12-lead ECG time interval on cases where the patient is 35 or older and presenting with non-traumatic chest pain. That's a pretty widely used metric in EMS STEMI care, but these EMS leaders were alarmed to find that over the last 2 months, this important time interval was actually increasing, and this is just the third month they have been measuring it. The local hospital where the medical director works has been struggling to get their median EMS first medical contact to device time intervals on non-transfer cases below 90 minutes, so this may be an important revelation for them. A detailed class on EMS STEMI care was presented to the EMS field staff about 6 months ago, and the importance of getting an early 12 lead on cases with potential acute coronary syndromes was explained. The various time interval goals for EMS in the hospital and the system of care was also presented. So the EMS medical director and the EMS managers decided that they now needed to aggressively address this problem of 2 consecutive months of worsening performance in the EMS FMC to device time interval by strongly reinforcing the importance and time urgency of getting that initial ECG to help the STEMI care process moving as quickly as possible in the event that the patient meets EMS STEMI alert criteria. So to accomplish that objective, they decided they would put on a mandatory CME class that goes back over the pathophysiology of STEMI and the relationship between total myocardial ischemia time and the increases in morbidity and mortality as that time interval increases. They decided that the class should highlight how the EMS first medical contact to initial 12-lead ECG time impacts the total myocardial ischemia time. They would then point out how that time has been increasing. The class would conclude with an announcement that any cases with longer than the agency's median EMS first medical contact to initial 12-lead time would require an incident report and receive additional review by the QI staff and the medical director. It's good that Somewhereville EMS is trying to use a data-driven process to identify issues and take corrective actions, but this scenario raises some questions that we'll get into shortly. And this leads us into our broader topic for today, the interpretation of variations in data and the myriad of problems that can occur when those variations are misinterpreted. When monitoring the performance of a clinical or non-clinical process, it's easy to misinterpret the variations. Some range of variation under normal circumstances occurs in every process, and variation that occurs within that normal range and shows no unusual patterns means that there's no indication or signal that the process is performing abnormally. So we call this a situation with normal variation, and no corrective actions for restoring normal process performance is called for. But sometimes variations are signals that something special or unusual is going on with the process. We call that special cause variation, and they need to be recognized, investigated, and addressed as appropriate. Unfortunately, misinterpreting normal for special cause variation or vice versa may lead us to take presumably corrective actions that can have very unfavorable consequences. And we see the negative consequences occur when normal variation is mistaken to be special cause variation that suggests there's an actual performance problem. Because there wasn't really a problem, this usually leads to a loss of time, resources, money, and sometimes even a decline in clinical or operational quality as we try to fix a problem that doesn't really exist, despite the best of our intentions. Similarly, mistaking special cause variation for normal variation means you're missing the signals that something unusual is going on, and you'll miss the opportunity to correct the problem or miss the opportunity to preserve progress if the variation was a signal of real improvement. So in this webinar, we're going to explore the differential diagnosis between normal and special cause data variation. We'll look at the potential consequences from misdiagnosis of data variation, and I'll introduce you to some tools that can dramatically improve the accuracy of your data variation diagnoses. So, how often have you attended a meeting or read a report where a number is presented that indicates what the performance of something was for the current month? Just that one number alone. Maybe something like a report that for April, your EMS agency or hospital or system level Utstein cardiac arrest survival rate was reported to be X%. Depending on the context, that might be okay, but in the scenarios I'm thinking of, the target audience is usually being informed about how well things were going regarding a process, program, or the overall organization. If everybody in that target audience is well informed about how things have been going in the past for quite some time and readily remembers what the numbers have been leading up to the currently reported number, that might also be okay. But in my experience, that's usually not the case. Without immediately recalling what the number was for the previous month, it's difficult or impossible to know if that one number now being reported is higher or lower. It's a little bit better when a comment is made that this one number is higher or lower than the previous month. Even better, the specific number from last month is stated. Now you can calculate in your head how much of a change there is. Better yet, both numbers are given and the presenter or the report does the math for you. Maybe even you're told what the percentage of change is from that previous number. But regardless, it's hard to really make much of an assessment on how things are going with just two numbers. You really need more history on what the numbers have been over a period of time to get a better sense for how to properly interpret what this month's number says about the performance of your process. A change in the number from one month to the next month does not mean there's a trend. Sadly, this is a very common misinterpretation problem. So much so that we have a tool specifically designed to remedy this problem, and it's one of the most basic and important data visualization tools we have in the quality toolbox. It's called a run chart. Run charts are commonly used, but they're often misinterpreted. There's some very specific guidance for how to interpret a run chart, and that's what we're going to get into today. The run chart is a graphical display of a set of data points that are shown in chronological order over a period of time. The customary way of showing the data points is with the value of the number being reported on the vertical axis, also called the y-axis. Usually the lower values are at the bottom and the higher ones reaching upwards. Time is usually on the horizontal axis, also called the x-axis. Usually the most current point in time is to the right side of the graph, and the oldest data is on the left side. Let's look at an example. Suppose that our colleagues in Somewhere County have a formally organized STEMI system of care. They participate in a regional EMS advisory committee, or REMSAC, that includes all the major players that deliver emergency care. The REMSAC has a STEMI meeting every month to review performance data on the various aspects of their STEMI system of care. And one of the key performance indicators they focus on is the symptom onset to device time. It's their best approximation of total ischemia time, which is how long an acute episode of myocardial ischemia lasted before the coronary artery was reopened. And the research shows us that the longer that the period of total ischemia lasts during a STEMI, the more of the myocardium is lost and the worse the outcome. Hence the commonly used phrase, time is muscle. So the REMSAC is trying to decide how to do things to reduce that symptom onset to device time. So they need to know if the performance of the system is getting better or worse. They need to know if any of the changes they have made or will be making to the system of care is resulting in an improvement, or things staying about the same, or maybe they're actually getting worse. So to help them track performance, all of the PCI hospitals submit data to a clinical registry database, like the chest pain MI registry from the American College of Cardiology. These types of registries can collect and analyze information from all of the STEMI cases at all of the participating hospitals. So Shortly after the end of each month, the PCI hospitals all send their event time data for each STEMI case to the REMSAC. The data from all of the hospitals is combined to allow a regional calculation to be made for the total cardiac ischemia time, which is calculated from the acute symptom onset time to the opening of the artery in the cardiac cath lab. All of those time interval values are put together to calculate an average, and a run chart is then generated from that system-wide average result. The monthly data points are connected with a simple line. Looking at their last 3 years of data with monthly data points, we get this run chart. Being able to see the data in this graphic format, a data visualization, gives us a much better idea of how things are changing over time throughout the region that the REMSAC serves versus just looking at the latest time interval number by itself. But one of the issues to address in using run charts is how often to add a new aggregate data point. We often think in terms of a day or a week or a month, quarter, or year. In general, I suggest you add new data points as often as you have enough cases to be representative of how well the process overall is working. Just 1 or 2 cases is really not enough. Hundreds is more than needed, so 10 or so is probably a good place to start. So if you consistently have around 10 cases or so a week, add data points weekly. If it takes a month to accumulate that many cases, then add a data point monthly, and so on. The advantage of having new data points added more often is that you get to detect changes in performance sooner than later. So if something's going wrong, it's better to know as soon as possible so you can intervene. If something's going better, you can try to lock in that change as soon as possible to make sure that progress is sustained and maybe spread that change to other places. The number of measurements needed to put a new point on the chart is a bit of a trade-off, though. Larger batches of measurements for each data point add some precision to the picture of how things are performing, but you don't get to see changes as quickly. Smaller batches of measurements from each data point does not give as precise of a picture on how things are working, but you can detect changes sooner. So 10 or so cases in the time period for each data point can give you a nice balance. It's okay that sometimes you may have a few more or a few less than the typical number of cases, but as long as it averages out around 10 data points per time interval, you're probably in good shape. You can also consider adding a new data point based on a fixed number of new measurements or cases. So instead of adding a new data point at regular time intervals like each week or month, you add a new data point with each set of new consecutive cases. You might choose 10 cases for calculating each data point. But once you decide on how many cases per data point, stick with that number of cases per data point. And this approach may be particularly helpful when you have seasonal swings in the numbers of your cases. So with a run chart, you now get a clear view of how things are changing over time. It lets you see if things are generally getting better, worse, or staying about the same. These types of assessments get us into the realm of trends. So, how much of a change is needed over time to be considered a trend? This is an extremely important question, as it'll influence your interpretation of the run chart and thereby influence your management decisions about how to react. So, I suggest that you think of it this way. Looking at just one data point is like looking at a snapshot. Looking at a run chart is like watching a movie, a lot more information. So now that we are looking at run charts, we need to interpret them correctly. Of course, you can just look at it, see all of the variation, and get a general impression of how things are doing, generally going up, going down, or staying about the same. But sometimes it's not so clear. There's a big pitfall here you should be aware of. If you're going to be making a decision based on the run chart, you should be a little more certain about the interpretation than just casually eyeballing it. A significant change in the behavior of a process isn't always obvious, So it's extremely helpful to understand a bit about the nature of process variation to help you know when the process is sending signals that it has actually changed and when it hasn't. You see, all processes have variation. The variation may be big, it may be small, but every process will have some variation. So let's refer back to that original example from Somewhere County EMS. Many STEMI systems of care track the time interval between EMS making contact with the patient and the time that the first 12-lead ECG was acquired if the patient was over 35 years old and presented with non-traumatic chest pain. Those cases are used because it's usually pretty clear-cut for needing a 12-lead ECG. So as soon as the patient complains of chest pain without associated trauma, the process of getting the 12-lead should start right away. But that time interval will not always be exactly the same, even when the crews are all consistently following the same policies, processes, and protocols. Here's a run chart of data from a different EMS system with their contact time to first 12-lead ECG acquisition time on consecutive cases with patients over 35 years old that presented to EMS with non-traumatic chest pain. There were no new initiatives, no new protocols, no new procedures introduced while this data was being collected. So the scattering of results represents the amount of natural variation in this process. The random differences in the time intervals may be from things like the chest pain being mentioned by some patients right away, or in other cases, the crew only finds out about the chest pain after they were told an elaborate story about the patient calling 911 after they spoke to their sister in Nebraska, who's a retired nurse with two really cute cats named Bang and Boom, and that her sister found them as strays after they were frightened by fireworks this past 4th of July. Or maybe some of the patients did not speak English well. Or maybe some of the patients were slow to agree to have a 12-lead ECG. But in any case, there can be all sorts of reasons for the process variations, even when everything in the patient assessment is going just as it's supposed to be. So, with this understanding that there will always be variation, we can now appreciate that we need to be able to tell the difference between the variation that commonly takes place in situations like I just described, which is referred to as common cause variation, and when the variation that shows up when something uncommon or special is taking place, which is referred to as special cause variation. So consider another scenario, one where a software upgrade with a bug is installed on all of the ECG monitors. That bug is now causing delays in all of the monitors used for capturing the ECGs, and now the whole 12-lead ECG acquisition process is taking longer for the whole organization. This is the kind of issue that would show up in run chart data as special cause variation. Now, sometimes when you're monitoring a run chart, you'll be wanting reassurance that things are performing up to expectations and staying on track. So if you see special cause variation showing up, it constitutes a red flag of sorts that can let you know that some investigation is needed to see what's going on and why. But sometimes special cause variation showing up is exactly what you want to happen. If you've recently launched an improvement project, you're intentionally trying to create special cause variation. The change at the core of your improvement project represents a change to the design of your process. The hope, your hypothesis, is that the change you made will result in a change in performance from where it is now to something better. So if you don't see special cause variation start after you made the process change and you've given adequate time for something to happen, you may need to conclude that the change did not make a meaningful impact, and it might be time to try something else. That's important to know, and the run chart can help you with that. Similarly, maybe the change made things worse. It's also good to know that, and that might lead to a management decision to stop the change and roll it back to where things were before, or just go back to the drawing board and come up with another improvement idea to try. So now we know that we need to differentiate between common and special cause variation when looking at our run charts. When you look at the run chart and see the variation, you should be looking for signs in the data that strongly suggests something unusual is taking place. These are called statistical signals, and these signs or signals show that something has changed in the process to a point that these signals start showing up in your run chart. They're revealing likely special cause variation. When these signals are not showing up in the run chart, it strongly suggests that the only variation we're seeing is from common causes. But it's also important to note that these signals, or the absence of them, is not 100% reliable. There can be, in some instances, albeit rare, when you get one of these statistical signals and it just happened to be the result of common cause, not special variation. But generally, they're going to be quite reliable. Fortunately, there are tools that we can use with a run chart to help us differentiate between these common and special cause variations, and they're called run chart rules. Each of these rules reveal a statistical signal in the data that strongly suggests that the process has changed. So let's start looking at some of these run chart rules. The first run chart rule we'll cover is for trends. In the context of run chart data interpretation, we say that there's a trend when there are at least 5 data points in a row that are all rising or all falling, but with a couple caveats. For adjacent data points with the same value, skip one data point and then count the rest. A set of data points of the same value doesn't make or break a trend, and the first data point does not count. So with these caveats, understand that this sort of pattern with 5 consecutive data points rising or 5 consecutive data points falling does not usually occur randomly. Something special has to be going on to cause this pattern to show up in your run chart. And that pattern is one of the statistical signals that I've been talking about. So here is what a rising trend looks like. In this case, we have 5 data points in a row that are rising. Again, not counting the first one and counting the 2 points at the same value as 1. It can also go down, as we can see in this example. Let's look again at the run chart of the EMS contact to first 12-lead ECG time intervals to see if there's any trends. Nowhere do we see at least 5 points in a row all going up or going down. No trends there. But here's where many people oftentimes misinterpret the chart. Too often, as the data flows in, people see a few data points in a row climbing up or down, and they call it a trend. There isn't a statistically valid signal here that the process has changed, though. Calling this a trend is an error in interpretation and can lead to some of those bad decisions we've talked about. To see what I mean, let's rewind the data movie shown in this run chart. Let's pretend that they only started collecting data on the EMS contact to first 12-lead ECG time interval at the same time they changed to the new super-duper rapid patch ECG electrodes. This is where I have indicated that introduction of the product with an arrow. These new electrodes are supposed to make the process of getting a 12-lead in the field go much faster than with conventional electrodes. So putting these in place is being conducted as a QI project to try to reduce the EMS contact to first 12-lead time interval. After collecting these first 4 data points, the medical director sees that the EMS contact to first 12-lead time is getting longer, not shorter. He's ready to call the QI project off in defeat and insist that the electrodes get pulled from all the units. But let's not pull the plug on the project yet. Let the run chart data movie continue to play with more data flowing in. We can see that in reality, those first several data points did not meet the definition of a trend. It wasn't a valid statistical signal suggesting a decline in performance. It was all just normal process variation. So prematurely pulling all the new electrodes may not have just wasted resources, but it also might have missed a great improvement opportunity if it turns out that with further analysis over a longer period of time, the new electrodes demonstrated that they actually made a big improvement in the time intervals and not made it slower. After all, time is muscle, and we want to do whatever we can to save time, to save more muscle, to improve more lives, to save more lives. So let me reinforce a couple concepts here with that example fresh in mind. Correct interpretation of a run chart requires us to be able to differentiate between common and special cause variation. Misinterpretation can lead to bad decisions, and run chart rules are used to help us make that differentiation between common and special cause variation. We just looked at one of the run chart rules for trends. When the variations we see are random, that's a pretty good sign that the process is operating in a very consistent manner. Now, it may be consistently showing wide variability in performance, may be consistently good, may be consistently bad, or consistently somewhere in between. The point is that in the absence of statistical signals pointing out non-random or special behavior, the process is performing consistently at whatever level it happens to have settled itself into. That random variation we see in that consistently performing process, again, is called common cause variation. It's just the common everyday stuff or noise going on in the background that produces the variation. But in contrast, when the variation of the process is non-random, those statistical signals will start to show up in your run chart. That non-random variation is referred to as special cause variation. Something different seems to be going on. It's a flag for someone to take a closer look to see what's happening. If that something going on is bad, you'll want to find a way to stop it and prevent it from happening again. If it's a good change from the normal process performance, you'll want to understand why and maybe share it and try to make it happen more often, or use it to help establish a better performing new normal. So let's move on now to the next one, the shift. This run chart rule is applied when you have 6 or more data points in a row that all land above the center line, or there are 6 or more in a row that are all below the center line. And the center line is the average of the data points taken from a baseline data collection period when we're confident that there were not any special cause circumstances taking place, or where we have excluded those special cause cases before calculating the average level that defines the center line on our chart. When a process has just common everyday variation going on, it's very unlikely, statistically speaking, that 6 or more data points in a row all land above the center line, or that they all land below it. So let's look at another example. A local emergency department started a rapid cycle improvement project to reduce their arrival at triage to 12-lead ECG time on STEMI patients that presented as walk-ins. Looking at data from their STEMI registry records, they have been averaging 14 minutes 21 seconds, or 14.4 decimal minutes. And decimal minutes is the way the programs like Excel will often show fractions of a minute. The ED staff leadership thought they could do better, so they formed an ad hoc QI project team to take this on. The cardiovascular nurse coordinator, having some strong QI training, knew that once a quarter data points were not going to be frequent enough for their rapid cycle improvement process. They wanted to make an impact in the next couple of weeks. So they decided to make sure that their STEMI cases were getting abstracted into the registry within a day or two after patient discharge, and then export the data from their STEMI registry every week to plot their triage to ECG times for every eligible case that comes in. Each case would be plotted on their run chart in chronological order. They have roughly 100 chest pain cases a week come into their ED, so they use the last 100 consecutive cases to establish their baseline. The coordinator knew a couple of cases with unusual circumstances in that process, so they were excluded before the average value for the triage to first 12-lead ECG time was calculated. That baseline value is used to define how the process is operating now, so any changes that come in the future can be compared to the baseline to see if the performance of the process has changed. An average or median is calculated for the performance during that baseline period, and that becomes the value of the center line that's plotted on the run charts, as I mentioned earlier. So here's what their baseline run chart looks like. It's important to note but they were not making any changes to their process during the time the data was collected from these 100 cases. They applied the complete set of run chart rules and did not see any evidence of special cause variation in those 100 cases used for the baseline. The average triage to 12 lead ECG time interval for these 100 cases was the 14.4 minutes, and that's the value you see for the center line. The team looked at the peer-reviewed scientific literature and looked back on some of the presentations they've seen at conferences and articles in trade journals to identify some best practices they thought they could apply to their emergency department. They took what they thought were the most promising ideas that could be applied to their setting, adjusted those benchmark process ideas to fit their circumstances specifically, and then implemented those changes starting with case number 101. Remember, the baseline cases were the first 100 cases. The QI project team, by introducing changes for their process for how and when a 12-lead ECG is acquired at the emergency department triage desk, is intentionally trying to create non-random behavior. They're hoping that the status quo in the baseline results is disrupted. They're hoping to provoke favorable special cause variation, showing up with shorter triage to ECG time intervals. So we want to know about a change in process behavior as soon as it's possible after it starts to happen. We watch as each new weekly batch of cases are added to our run chart, and we anxiously hope to see those statistical signals that tell us when a significant process change has started to take place. If our process change is not effective, we will not see the favorable special cause variation show up. Remember, monitoring a run chart is like watching a movie. Each data point is like a new frame in that movie. So let's look at the run chart movie. It'll start out with the baseline data in view, and we'll start adding new data points. I obviously already added all the data to the chart, but for purposes of this example, imagine that we are accelerating time and watching new points as they come into view as cases are entered into the STEMI registry.
We start out seeing data points 81 through 100 on the screen. These are the last 20 data points from the baseline period. As the data is added to the chart will move to keep the most recent 20 or so data points in view. This is called a moving data frame. The new process is implemented, and the results from the new process will start with case number 101. In this simulation, the data is being added pretty quickly, but soon we can see that fewer and fewer data points are showing up above the center line. This is the shift that we have been talking about. The ED arrival to first ECG times are getting shorter, and as a result, the position of the data on the graph is shifting downwards. It's pretty easy to see this well after the change has taken place, but since we want to know as soon as possible so that we can lock in the process change, or if the shift is bad, we can terminate the process change and try something else. The run chart rule for detecting a statistically significant shift gives us that early indication.
It can be hard to tell if and when a shift occurs. Remember, it is at least 6 consecutive data points above the center line or 6 consecutive points below the center line. It's often pretty obvious to see the shift well after it's occurred, but we want to know as soon as possible. So let's watch the data flow again and apply the run chart rule for detecting a shift as the new data is added along the way. Remember, we're looking to see if we find 6 or more data points in a row show up all over the center line or all under the center line.
We start out seeing data points 81 through 100 from the baseline period, and we'll watch for instances where several data points in a row are above or below the center line. Here we see several. 1, 2, 3, 4, 5. Not enough. Moving on. Here's another grouping below the center line. 1, 2, 3, 4, 5, 6, 7. So it's case number 162, where the first set of 6 or more consecutive data points below the center line first appears. This is more objective and reliable than just eyeballing on all but the most obvious scenarios. But even with just our eyes, we can see that the shift goes even lower over time, representing shorter time intervals.
I'm going to show you the same data again, but in a different way that I think is more powerful. Instead of adjusting the view of the run chart to show the same amount of data each time as new data points are added, which is sometimes called a rolling or moving data frame, we're going to make a longer graph with space already allocated to hold the new data in the same view. The advantage is that your eye doesn't have to readjust to the new view and take in the new data at the same time. You can focus on just the new data. And I think it helps you see how the new data compares to the older data much better. I also think that having the data points more compressed together when you have a lot of data is also helpful for your eye to appreciate the overall changes rather than just focusing on the last few data points. So let's take a look at that.
This first section of data shown here has the first 100 cases in the baseline period. The variation you're seeing in that baseline period is common cause variation in the process, just the normal everyday stuff or noise going on in the background. Data will start to be displayed in just a moment that came in after the improvement intervention began. Here we go. The point where the shift criteria is first met is right now. Not all that obvious to the eye alone at this early stage. As more of the data scrolls into view, you begin to see visually how the shift downwards takes place. You can see how the performance settles into a new normal range. This compressed view makes this type of visualization possible with larger sets of data points. This variation shown as the downward shift is one of the special cause variations that provides a statistical signal that the process is performing differently. In this case, it is performing better, which is what we were hoping for when we made the change in the process for how and when 12-lead ECGs were captured on ED walking cases presenting with chest pain.
So that's the run chart rule for shifts, and we've covered trends. I'm hoping this also gives you a better appreciation for some options in how your run chart data is formatted. Now let's move on and consider the next run chart rule for runs. When the variation we see in a run chart is just the common everyday stuff or noise going on in the background, we would expect that the data is going to be above the center line sometimes and below the center line sometimes. As a result, if the process is truly random, we would expect that the plot line would cross the center line, with a certain frequency. If it crosses it too often, it suggests something unusual is going on. It's a statistical signal. Same goes for not crossing the center line often enough. That's also a statistical signal for special cause variation. So, how do you know how many times it crosses the center line is too many or too few? It's a run chart rule, of course. To apply the run chart rule for runs, we count runs. And a run is a series of consecutive data points above or below the center line. And the easiest way to count the number of runs there are on a run chart is counting how often the line that connects your data points crosses the center line, and then add 1. We then use a table that lists the number of data points that are in your run chart that do not fall on the center line, or a section of the run chart, in case of the whole run chart, and then see how many runs are too few and how many runs are too many for that segment. Let's look at a quick example. On this view of the graph, just consider the section of the run chart on our screen. Let's call that the whole data frame. There's 27 data points. So now let's count the number of times the data line crosses the center line. And we can see that it crossed the center line 13 times, and then we add 1, as I mentioned earlier. That gives us 14 as a count for the number of runs in that section of the run chart. Now we look at a table of values for the run chart rule for runs. We have 27 data points, and the lowest number of runs we would normally expect to see if the variation is random is 10. And the highest number of runs we would expect to see if there's only special cause variation in a series of 27 data points is 19. So our result of 14 falls within those limits, so this section of the run chart does not seem to have special cause variation, at least on the basis of the run chart rule for runs. So that's how to apply the run chart rules for runs. And now to the last of the 4 run chart rules for outliers. The first 3 run chart rules we looked at were based on the statistical probability that the variation we were assessing was due to common versus special cause variation. But this last one for outliers is a little bit more subjective. It applies to the data points that are so much higher or lower than the others that it's obvious to most anyone that there's something unusual going on. The data point sticks out like a sore thumb. Every set of data will have a highest and lowest values, but those are not necessarily outliers. Let's take a look at an example. We're looking at some of the patient contact to first 12-lead ECG time data again. We see that the center line is around 14 and the data points are generally falling between around 5 and 25, except for that one point. That is much, much higher than the others. It's up around 38. That's an outlier. Sometimes an outlier may be so far away from the others that you have to question if the data is even valid. You might see a value for the patient contact the first 12-lead time interval for over 3 days. And gosh, I sure hope that's a data error, or we may need to send out a search and rescue crew to find out what's going on and provide some assistance on the case. But instead of relying on a subjective impression of a far outlier, there's another tool that we can layer on top of the run chart, and they're called control limits. And when control limits are added to the run chart, we call it a control chart. It's sometimes also called a statistical process control chart or Shewhart chart. And this is a bit of an oversimplification, but the control chart defines high limits and low limits on the range of variation that we would generally expect to see with normal variation. So when a data point falls outside those upper or lower control limits, it's considered to be far enough out of the normally expected range of variation that we'll interpret it to be a statistical signal suggesting special cause variation. Now, there's a lot of additional detail to get into with control chart interpretation, but for today, I just wanted to be sure that you were introduced to the run chart rules and control chart idea so that you can use them and understand how they can make you better at distinguishing between common and special cause variation, and then make appropriate management decisions accordingly. So there you have them all, 4 run chart rules for detecting special cause variation and the added bonus of a more precise way to define outliers with control limits. Trends, shifts, runs, and outliers. Special cause variation is the thing you watch out for. If you're not intentionally changing the process, a statistical signal or outlier for special cause variation strongly suggests that something unusual, good or bad, is going on and may warrant investigation. If you're doing a QI project and are changing the process, look for special cause variation as evidence that your change is actually making a difference in how the process performs. So let's go back to the Somewhereville EMS scenario we started with. They decided to create a more targeted CME class that goes into more detail about the pathophysiology of STEMI and the relationship between total myocardial ischemia time and the increases in morbidity and mortality as that time interval increases. They decided that the class should highlight how the EMS first medical contact to initial 12-lead ECG time impacts the total myocardial ischemia time. They would then point out how that time has already been increasing. But if the crew's already received this type of content earlier in CME, and in most of these sorts of program rollouts, that's pretty standard content. So covering the same information again may not accomplish much of anything other than spend money and time. It can also create hassles for the crews needing to attend an additional class, and it can also create some frustration with the crews when they're having to take a class that's covering material they already know. It's all quite counterproductive. And they also said that they were going to require an incident report and take a closer review on all the cases with longer than the agency's median EMS first medical contact to initial 12-lead ECG time. But realize, by definition, that would be half of all the cases that fall above the median. So what in effect they're doing is treating anything over the median as special cause variation. Again, a wasteful, expensive, frustrating, and frankly, demoralizing strategy. The EMS medical director and managers had the best of intentions, but the lack of appropriate differential diagnosis in their interpretations of the data variations is getting them way off course. So, to summarize, when looking at the performance data for a process, the run chart is a rule we can use to assess the behavior of a process over a period of time or on an ongoing basis. And because processes have variation, the operational question we'll have when looking at the data over time is if the variation we see suggests that the behavior of the process is fundamentally changing, something we call special cause variation, or if the variation is just random and it's inherent to the process, something we call common cause variation. And the run chart rules can help us tell the difference and thereby lead to better interpretation of the data, and that leads to better decisions about how to respond. We want to react correctly by making appropriate data-driven decisions. Let's return to the live feed for your questions and comments.